Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
This activity includes discussion of off-license or unapproved therapies. Please consult your local SMPC or its equivalent for further information.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Alnylam Pharmaceuticals, Inc.
Hello, and welcome to this fast-paced discussion on the top 5 errors in transthyretin amyloid cardiomyopathy management. I'm Pablo García-Pavia, head of the Heart Failure and Hereditary Disease Unit at Hospital Universitario Puerta de Hierro in Madrid, Spain, and it's my pleasure to welcome you to this activity. Transthyretin cardiomyopathy has emerged as a frequent form of heart failure nowadays. We now recognize that this, which used to be a neglected disease and which was thought to be rare, is more common than previously thought. And it has certain particularities regarding its management and how to follow these patients. Therefore, very frequently there are certain mistakes that can be common. And today we're going to try to address some of these ones in order to help us and help you in handling these patients in the clinic. I'm delighted to be joined by my good friend, Dr. Drs Sperry, who is a cardiologist and an amyloid expert from the Mid-American Heart Institute in Kansas City in the US. So Brett, welcome.
Thank you. Thanks for having me.
The game today is the following. We are going to track real-world challenges and give practical solutions. That means about 1 or 2 minutes per question. So, Brett, let's make every second count.
All right, Pablo, thank you so much. And again, it's a pleasure to be here with you for this quick fire challenge. And so we're starting off, you're on the hot seat here. We're going to give you a couple minutes here to answer this first question, and we'll see if you can do it. So the first question really, and we're focusing on the top errors here that are being made out there in transthyretin amyloidosis. One error that I see sometimes and we hear about is that if the heart has amyloid in it, right, with the biopsy or nuclear scan, but the patient does not have heart failure symptoms yet, and then disease-modifying therapy is not actually started. What do you think about that? We'll give you 2 minutes.
Okay, I'll try to do it very quickly. So we know nowadays that the mechanism of actions of the drugs that we have do not remove the amyloid that is already deposited in the heart. What they do is they prevent further accumulation of amyloid fibrils. Therefore, it seems obvious that the earlier we start the therapy, the better results we will achieve because there will be less amyloid accumulated in the body. But it's not only that it's somehow obvious, it's that we have data supporting that. There are data from the ATTR study with tafamidis showing that those patients who were on placebo during the study and who then transitioned to the long-term extension study did worse than those patients who were on tafamidis from the very beginning of the double-blinded period. So therefore, that supports that the earlier you start the therapy, the better results. But it's not only the TRACK study. Here you can see the data from the acoramidis study, the ATTRibute study, and again, after 30 months, patients both in the placebo and the acoramidis arm transitioned to open label acoramidis. And you can see here that the curves still diverge after that transition. Again, the latest study from a disease-modifying agent, which was the vutrisiran HELIOS-B study. Also, last year we presented at the ESC Congress in Madrid the same findings. Those patients who were on placebo, who transitioned to vutrisiran in the open label, did worse than those who were on vutrisiran from the very beginning. And what is more important, those who, when they start, they don't catch up, they don't improve as much as the ones who started early.
Great work. We had it. 2 minutes exactly. Fantastic. I think we also have real-world data as well in patients who are asymptomatic or minimally symptomatic, showing that they do progress over time fairly quickly within a few years. And it's, as you said, it's the natural history of the disease where it is going to be a progressive disease. And so really diagnosing these patients early, once they have amyloid infiltration in their heart, and certainly if you see any sort of signs of clinical significance there, whether it's symptoms, elevated NT-proBNP, AFib, other types of things, we really need to get them on treatment as soon as we can.
And do you think we will eventually treat patients in the future without having amyloid in the heart? I mean, patients at risk, like those with carpal tunnel syndrome, deposits of amyloid, or those who are carriers of a genetic mutation?
Yeah, we'll have to see. I mean, I think the carpal tunnel is difficult because we definitely have some people who have carpal tunnel and then don't seem to progress over many years. But in gene-positive patients, we have an ongoing study right now who are genotype positive but phenotype negative to see if a disease-modifying therapy will prevent them from developing clinical amyloidosis in the future.
Well, now we're going to move to the next question. Brett, here is the second error. So some people say, I've always stick to tafamidis because I'm comfortable with it. So we just saw the data that there are 2 additional agents that have been approved since tafamidis. How do you decide in your clinic between the different disease-modifying therapies that are available nowadays? You have a couple of minutes.
No, that's a great question. And I think it's important to just set the framework of the different disease-modifying therapies that are out there. So, we have the TTR stabilizers, acoramidis and tafamidis. They work by stabilizing the protein, keeping it bound in its current form so that it doesn't break down further and deposit into the heart. And then we have the silencers, vutrisiran, which is approved for cardiomyopathy and polyneuropathy, and we have eplontersen, which is approved for polyneuropathy, but an ongoing study will be presented very soon on cardiomyopathy, which works by really destroying the messenger RNA, the signal that then leads to the protein production. And so these are our options in the United States, and so we really have these 3 options now available for cardiomyopathy. And we're in a lucky period of time. It's much different than many years ago when we didn't have any therapies. Now we have 3 therapies that improve longevity, improve quality of life, improve functional capacity, hopefully with a 4th on the way. And so I think that there's a specific population where I will pick a silencer, and that is people with a hereditary ATTR cardiomyopathy. I'm seeing them as a cardiologist. If they also have concomitant polyneuropathy, we do have data for the polyneuropathy with the silencer. So I'll pick a silencer in that scenario. Otherwise, there's really no head-to-head. These trials were all done in different eras, so it's tough to know, is one better than the other, or are they all just working down the same pathway to prevent more amyloid accumulation? So the biggest question really is, does a patient want a pill or a shot? This is what I try to get at with patients. Patients will have a clear understanding of, do they want another pill or not another pill? And then we kind of go from there as far as the decision.
You did very well, just below 2 minutes.
Yeah, it's tough to get that in. We can all talk for much longer about this than just the 2 minutes. So thanks for the opportunity there. But I'm going to turn it over to you for the next part. We're going to give you 90 seconds for this. The next error we're going to talk about is recognizing patients who are progressing despite disease-modifying therapy. So in your clinic, how do you follow patients over time? How frequently do you follow them? What do you look for? And then how do you recognize patients that are progressing?
Yeah, we follow patients every 6 months. If they are doing okay, that's what we do. And previously it was difficult to decide who is progressing and who isn't. But very recently there was a publication from a group of experts, and I had the privilege to be part of it, to set a common ground for everybody in order to assess if a patient is progressing or not. We defined 6 different parameters that have been described and validated. And the change in them after 12 months are related with mortality down the road. And these parameters are distributed in 3 domains: the clinical, the biomarkers, and the functional domain. and the clinical includes heart failure hospitalization and worsening heart failure, outpatient worsening heart failure with increased dose of diuretics. Biomarkers NT-proBNP and eGFR increase. NT-proBNP is more than 700 and more than 30% compared to the 12 months earlier value, and eGFR is a relative increase of more than 20%. Then the functional parameters are an increase of more than 35 meters in the 6-minute walking test and a decrease in KCCQ of more than 5 points. So if somebody progresses more than 2 of these, we consider that is progressing, and that's the definition. We will see what we do with that now, but at least that's the definition that we have.
Yeah, that's great. And I think, I think that when you look at this, how you guys have framed this, I think the first 4 are really related to congestion in a way. You have heart failure hospitalizations, diuretic intensification, NT-proBNP changes, and kidney function changes. At least for me, there are some patients that have worsening congestion as a disease progression, but then you also have patients that seem to have just worsening functional capacity without congestion issues. And those are very hard to understand what to do with. I think that can be because it's an older population and they're just getting older and weaker and able to do less. It could be because of all the orthopedic manifestations that these people have, and it could be from heart failure, low output type symptoms that lead to worsening functional capacity. So at least for me in my clinic, I think we have a lot of good decongestion strategies, which we'll talk about, but it's really the functional capacity part that seems to be progressing the most in patients.
Okay, let's move forward to to the 4th error that I see. And I will say is related with the previous one is, what about people that after assessing that the patient is not improving, I mean, actually is doing worse, they don't do anything? What do you do? You have 2 minutes.
That's a great question, and I think I similarly to you will follow patients about every 6 months, look at a comprehensive panel of their biomarkers, their functional capacity, whether they've been hospitalized or not, and really try to understand, is a patient progressing or not based on these criteria and this framework that you guys have put forward. I think one thing I do specifically is look at other causes for disease progression. We talked about, and we can talk about in the future, other things, atrial fibrillation, bradycardia, chronotropic incompetence, coronary disease, untreated congestion, these types of things. Anything else I can do to help them. When we get into specific disease-modifying therapy, what do I do with that scenario? Again, in the United States, we have the ability to be on any of these 3 medications. There are some patients that end up on combination therapy. The problem is we don't really have data to know, is this the right strategy? Is this actually going to be helping patients? We don't know if 2 is better than 1 as far as combination therapy. We don't know if one of these agents is better than another. I think it might be natural instinct to think, okay, I'm going to switch one to another if someone's getting worse. But the reality is we know this is a progressive disease, and it does create a lot of logistic headaches and anxiety and other things when we're switching medicines or we don't have confidence in the therapies that we're providing. So typically am not necessarily switching medications if people are progressing. I think one thing that we need to talk about also is just the ongoing clinical trials that are really out there, and there's a ton, all the way from gene therapy to additional silencers to depleter therapy. So really, if you have a patient that is progressing at your center, you can really offer them a clinical trial or get them to a center that has clinical trials to be able to consider these things.
Well, I mean, that was a tough question, and it was really good summary of what to do. Let's go for the last one, which is, I'm going to keep you in the hot seat for the last question. Patients with TTR and heart failure frequently receive the same combo of medication that any other patient with heart failure. Do you think that's correct? How would you handle that?
Yeah, I think that is a common error, maybe the most common error that I think I see. And oftentimes it's not an error, because if people think that someone just has regular HFrEF, for example, or mildly reduced EF. Patients get treated in a certain way with beta blockers, with ACE inhibitors, with certain strategies. But then once you understand that they have amyloid, then it changes things. And I think that a lot of the symptomatic improvement that we see in patients early happens because we're changing some of their other medications and putting them in a better position to have a better quality of life with the restrictive cardiomyopathy that they have from the amyloid. So for me, I try to reduce ACE inhibitor, ARB, ARNI dose because oftentimes it leads to hypotension and that causes symptoms in patients. I try to promote SGLT2 inhibitors and MRAs if I can. Patients on heart failure therapies and diuretic type therapies to spare some of the dose of the loop diuretic that people are on. And then the beta blockers are tough because, as you know, probably 75% of these people will have AFib or will get it at some point in their life. So sometimes you do need to be on beta blockers, but frequently they're bradycardic with their AFib. Yeah. So de-escalating the beta blockers, I think it improves their quality of life. Initially, optimizing decongestion is another one after they're on the SGLT2 and the MRA, as far as being on a loop diuretic or additional diuretic strategies. And so again, really just optimizing those upfront, I think helps people and can allow time for these disease-modifying therapies to work in the medium to long term.
Very good. That was not easy, and you did it. You nailed it just before 2 minutes. Congratulations. I will say that it's certainly critical to recognize these patients and start therapy as soon as possible to obtain better results. What will be your messages?
Yes. No, I totally agree. I think diagnosis is key, finding patients early, really thinking about it. If you're not thinking about it, then you're not going to diagnose it. And then once you know what's going on, it's important to shift your mindset, like I was saying. You're not taking care of someone with run-of-the-mill dilated cardiomyopathy anymore. They have a restrictive cardiomyopathy with amyloidosis, and thinking about the disease-modifying therapies and then the non-disease-modifying therapies that can help improve their longevity and quality of life.
Well, thank you very much, Brett. It has been really a pleasure to share the stage with you, and really thank all the audience for being with us today. And I remind you to complete the questions that follow and answer the evaluation. Thank you very much for joining us, and we hope to see you around here very soon.